Okay, thank you, everyone. Today's topic is we are looking at impact of HIV and AIDS in Zambia, and I am so pleased to bring Dr. Ketty Ngona, who conducted years of research on HIV and AIDS among population in Zambia. A lot of people may ask why we're talking about HIV. I mean, it's important because at some point it was a pandemic and it's still plaguing a lot of communities around the world today. Yes, the prevalence has gone down. Yes, we have had a breakthrough in terms of getting therapy that works for HIV, but HIV is always a reminder for the world to know what's about to come or what will come in the future, and not only saying that we just saw COVID-19 pandemic happen, so pandemic will always be there, but once we prepare enough and understand how these things happen, we can be able to fight some of these when it do happen. You can turn your camera on if you want, but please mute your phone if you're not speaking. We will provide an opportunity for everyone towards the end to ask questions to me or to Dr. Ketty Ngona. Before I introduce Dr. Ketty Ngona, let me briefly give everybody a unique background of HIV. In 1979-78, HIV pandemic onset started. There were limited information about HIV. There's a lot of misinformation, lack of facts and accuracy of mode of action and transmission of HIV pursued. There's so many political misinformation. In fact, HIV was observed in young gay population participating in hepatitis B vaccine clinical trials in Manhattan, New York, San Francisco, and other parts of the country. The pandemic of HIV/AIDS among this population led to the false assumption and stigmatization of the infection and disease as a gay plague. Then, scholars, many came with all these weird theories and hypotheses about chimpanzee and monkey hypothesis, which also we know now, many of those are just a lot of noises. Then there were travel ban policy initiated. Some deemed it as unethical. Now, HIV discrimination also was really prevalent until civil rights stepped in. And then in 1988, the US government banned HIV discrimination. The American Foundation of AIDS Research awarded its first grant to Dr. Peter Piot for his study for female to male HIV transmission in Kenya. FDA authorized the condom manufacturers to claim that condom can prevent HIV transmission when used properly. And then due to public health and political pressure, the FDA in record time approved the first anti-HIV drug, zidovudine, commonly called AZT. Please, if you're not talking, put yourself on mute. We appreciate that. This AZT was approved in 1987. And in fact, the AZT clinical trial started in 1985, and then the drug was approved in 1987. But note, though, in 1964, AZT was actually synthesized at Wayne State University, way before HIV, by Wayne State University for cancer therapy under the U.S. National Institute of Health grant. AZT became the most expensive drug in the market at $10,000 for 1 year supply, which is roughly about over $800 per month for the drug. Scientists also discovered that AZT was not effective or safe. AZT was toxic cause harm to patients with HIV. In mid-1990s, more information came out. Scientists discovered a gene, I don't know, many of you know that, is CCR5 delta 32 allele. Individual with CCR5 delta 32 homozygous allele confers complete resistance to HIV-1, LAV infection. Those that have heterogeneous carrier of the allele may develop AIDS in a slower pace. The delta, this CCR delta 32 is localized in European descendants, and thus far has not been found among Africans, Amerindians, or East Asians. Among the European population, the CCR5 delta 32 mutation is 18%. And you know how mutation happen, it just don't happen in 1 year, 2 years, a decade of gene mutation. Current scientific date in using skeleton remains roughly 2,900 years old. In Northern Europeans, the CCR5 delta 32 mutation was actually dated at about 5,075 years old mutation and cannot be attributed to recent disease epidemic. There is a correlation also between a long-term estimate of lactose tolerance in Europe to emergence of CCR5 delta 32. So I just wanted to give this basic background of, history of HIV and what we now know after all the, years of misinformation about HIV. We now scientifically have done many, not me, but many institutions has done many research on this, and they're finding a lot of stuff. And we will see similar thing happen with COVID-19 in the next maybe 10 years. We will even get more information that people don't have in the past. For the sake of this presentation, I usually want to start with quotes when I do this podcast. One of the quotes is an Igbo quote. It says in this way, "Onye amara ibe esi n'ozu na-esi n'ọkpa," and the abo. And this English version means a person who does not know where or how a corpse is buried, excavate from the leg or lower extremities. This it has a cultural significance because usually you go from the head down. And I believe in my quote is that also another quote I will use for this presentation is that the worst enemy knows everything about a prey, and the prey knows nothing or little about the enemy. So I believe as a public health expert that our enemy is always diseases, whether it's infectious disease or chronic disease. We have to know more, to talk more, and to do more, and to do better in preventing this type of diseases. And without further ado, let me actually introduce Dr. Ketty Ngona. Okay, so Dr. Ketty Ngona is an epidemiologist with a diverse range of accomplishment and a passion for improving public health. She is also a board-certified nurse practitioner for adult care and mental health practice with more than 13 years of dedicated work experience. Dr. Ngona finds solace in serving underserved community. She is driven by compassion and desire to promote positive change in people around her and actively promote quality of life, better health outcomes, and disease prevention strategies. Beyond her professional commitment, Dr. Ngona is an active member of Agape Church International. Her faith and involvement in church community play a significant role in shaping her values and perspective. She finds solace and inspiration in her spiritual belief, which further motivates her to serve others with a heart full of love and empathy. With an exceptional career and profound connection to communities and her faith, Dr. Ketty Ngona continues to be an influential figure in the community, promoting the quality of life of many people and creating a positive impact in the community. Dr. Ketty Ngona cherishes her role as a loving wife and a devoted mother of 4 sons, balancing her career and family life, exemplify her character, a strong and nourishing individual. Welcome, Dr. Ngona, to Popaholic Podcast. And I will now turn it over to you to give a shout out to your audience and your colleagues.
Thank you, Dr. Omelu. Hello, everyone. Thank you for joining in this afternoon. Others, maybe it's in the evening or morning. We appreciate a lot. And before I can continue with this podcast, I would just want to thank you, a number of people who contributed to this success of the dissertation. The first one is the chair who served on my dissertation program, Dr. Tolo. She was there at any time I called her upon to help me in every area where I needed help immediately. And I would also like to say thank you to Dr. Mel, who also came in handy when I needed him the most. And he was able to navigate around with me to make sure that this dissertation became a success story. Additionally, I cannot forget to mention my family, especially my husband, who was there all the time to make sure I had all the tools that I needed at the time when I was in despair. And then also for my children who were able to be patient with me in helping them for their needs by also availing their time to me so that I can be able to complete my dissertation in a timely manner. And finally, I'm not forgetting to mention my the workers, especially the clinical director for Kena One Healthcare, the clinical, Mr. Latanya Tillman, who was also there when she knew the stress I had during the, the process. She would always run around to make sure that my day went well. And of course, not forgetting the Zambian Research Department, where I was able to get the data that enabled me to complete the research. Thank you so much.
Before we start this whole discussion, I wanted to know from Dr. Ngona, and many audience may want to know, what are the problems that you solved in this study? What are the background that prompted you or informed you for the study you conducted, and what are the purpose and significance of your study?
Thank you, Dr. Mel, once again. So the problem that led me to pursue this research was when I looked at the data from the Millennium Development Goals, which was conducted, I realized that in 2016, Zambia had 1.2 million people living with HIV and AIDS, of which 59,000 were new HIV infections and 21,000 were HIV and AIDS related deaths. And also adolescent girls and young women were more affected by HIV AIDS than men. In 2017, about 14.3% of women aged 15 and over were living with HIV in Zambia. And out of that number, only 8.8% of men aged 15 and over were living with HIV. The United Nations reported that Zambia had achieved the Millennium Development Goal target for HIV/AIDS prevalence reduction. However, it was not clear whether the MDG target for HIV/AIDS incident rates had also been achieved. Therefore, the purpose of the research was to evaluate the association between gender and HIV, marital status and HIV, and wealth index and HIV cases among individuals aged 21 to 65 years old living in Zambia in 2018, after controlling for age and educational level. The research not only did it inform the effectiveness of the MDG's efforts on HIV/AIDS in Zambia, but also benefited public health efforts on HIV/AIDS in Zambia. So when we look at the background, like Dr. Melu had mentioned earlier a little bit, we noticed that there were a number of researches that were conducted, and one of them was by Xavier Kante, Tani, and Phillips in 2015, which indicated that efforts were needed to minimize the risks of HIV infection and AIDS disease by promoting safe sex practices. The other one was understanding mother-to-child HIV transmission was an important factor in reducing HIV/AIDS epidemic. The other factors such as needle exchange, reuse for drug use contributed to HIV transmission. So it was important to understand the risk factors of HIV and AIDS to enhance and improve current HIV and AIDS prevention and management efforts in Zambia. So the purpose of the research was to evaluate the association between gender and HIV, marital status and HIV, wealth index and HIV, cases among individuals aged 21 to 65 years old living in Zambia in 2018, after controlling for age and educational level. And this research not only informed the effectiveness of the MDG's efforts on HIV/AIDS in Zambia, but also benefited the public health efforts on HIV/AIDS in Zambia. So when we come to the significance of this research, although there was an abundance of research on HIV/AIDS and prevalence rates, there was limited research on HIV incident rates. The results of the research added value to the literature on HIV by addressing the reasons for the increasing HIV infections in Zambia, despite the Millennium Development Goal targets for Zambia mentioned to have been met in 2015. The findings from this research could provide new information and a deeper understanding of the HIV/AIDS problem, which could have been utilized by planners, policymakers, lawmakers, and the Zambian people. Consequently, the new policies and interventions developed from the insight of this research could have been considerably reduced new HIV infections, which continued to negatively influence the performance of Zambia's fundamental social and economic development. So the significance and social implication is improvements were made to HIV and AIDS prevention programs. Decision-making by policymakers was enhanced, and this research highlighted the risk factors associated with HIV transmission.
Thank you, Dr. Ngona, for that overall brief summary of your problem, background, and purpose and significance. As you can see in that information I shared, you can see that South Africa carried that flag for a very long time in terms of prevalence, and it's not even compared to other countries. And I don't personally know what was going on in South Africa, but hopefully with a lot of information now that they're working to actually reduce the prevalence of HIV in that country. So I'm going to move forward to ask other questions about if you can discuss you kind of already mentioned about the research question that you addressed, but can you move forward to talk about the theoretical framework and methodology that you described? But then if you can come back to the research question, that's fine too. But what are the theoretical framework and methodology you use? We do this a lot because when you conduct a scientific research, there has to be certain rules that you have to follow. It's not based on your own personal opinion. It should not be based, let me rephrase, it should not be based on individual personal opinion, but based on a protocol, scientific protocol we are supposed to be using to conduct a study.
So the theoretical framework that was used in this research was the Millennium Ecosystem Assessment, which is abbreviated as MA framework. And it was first used in the year 2000. And its main purpose was to assess the consequences of ecosystem change for human well-being and scientific basis for action needed to enhance the conservation and sustainable use of these systems and their contribution to human well-being. So when it comes to the research questions that I came up in this research, there were 3 of them. And the first question was, what are the associations between gender and HIV in Zambia in 2018 after controlling for age and educational level? And research question number 2 was, what was the relationship between marital status and HIV in Zambia in 2018 after controlling for education level? Then the third question was, what was the relationship between wealth index and HIV in Zambia in 2018 after controlling for age and education? Those were the 3 questions. So the methodology that I used a cross-sectional quantitative method research. And I also used binary logistics regression to determine whether the independent variables significantly predicted the dependent variables. The data source was archival data, which was gotten from the Zambia Research Department that enabled me to conduct my research.
Thank you. So now that we get the most basic understanding of how this study was put together, can you move forward and describing the findings and the social implication of your study?
Okay, thank you so much. So in this research, a total of 6,966 men and women reported their HIV status. And out of the 6,966 men and women who reported their HIV status, 89% were men and 12% were women. So out of the number that I mentioned, the 6,966 men and women who reported HIV status, 11% were HIV positive and 89% were negative. So in this research, men and women who were included in this analysis, 9% men were HIV positive, while 80% men were negative. And those that reported their HIV status, 10% tested positive for HIV and 90% tested negative. The women who were included in this analysis, 2% women were HIV positive, while 11% were HIV negative. And out of the number of these women who reported their HIV status, 13% were positive with HIV and 87% were HIV negative. So when it comes to the results on the research questions that I mentioned earlier, so the first question, which was on gender, after controlling for age and education, men and women were the same in terms of positive HIV as well as being negative. And the age range which we looked at was 21 to 43, and then 44 to 65. So adults aging 44 to 60 significantly predicted HIV negative. And then when it came to the marital status, we looked at the married, divorced, widowed, and single. And after controlling for education, individuals who were widowed significantly predicted to have HIV positive compared to other population. And then when we came to education and gender, marital status, they had no education or primary education. So those that had no education at all and poor, they had a higher rate of HIV positive results. And education for wealth index and controlling with education, that is those that had no education or primary education had similar HIV tests for those who were middle class or rich. So we found that among the people who were rich and had a higher education level, they had less numbers in terms of being positive as compared to those that had no education and were poor. Those had a higher level of HIV positive numbers. So these are the findings that I came up with in my research.
This is interesting. Verification that education, whether it's formal or informal, education which leads to information, which also leads to knowledge, is actually consistently shows in many chronic conditions or infectious disease that it is a confounding factor or a predictor to all these adverse events. You know, even here in the United States, we see this all the time. I'm in public health, and we see whether it's cardiovascular disease, whether it is colorectal cancer. You know, the people in underserved neighborhood is always suffer most on this type of health condition. And sometimes I don't like we keep talking about it because it's like something we already know that exists. And then are we not doing enough, or are we just you know, like relaxing like it doesn't exist? So it bothers me a lot that over and over again, scientists from all different angles find the same thing. And it just like stays to me to seemingly like dormant, and nothing is moving. So we in public health, we in a medical field need to put more effort in awareness and education. It doesn't necessarily mean that that person had to go to college, got to go to university, but there's what you call health literacy. You know, if we can promote that more, then it will, I think it will help. It will balance out this education barrier and the education gap. Because you can also be educated and you still don't know much about health, right? So, but anyway, moving forward, let's talk about the lesson learned. I cannot talk about it, but anyway, but it's you. But the lesson learned that Dr. Ketty Ngona discovered overall in her research, and then what are the practical application of your findings in public health, clinical best practices, and community setting?
Okay. So I just wanted to mention briefly the lesson learned. We found that results of this research showed that the wealth index, age, education level, and marital status were significantly associated with HIV, negative HIV status. Therefore, promoting gender equality in all sectors of life could substantially reduce HIV risk among women and men. In addition, the likelihood of HIV infection among the vulnerable poor population living in hard-to-reach rural areas and those with little or no educational level in Zambia was higher. So by understanding these factors better, public health efforts could provide meaningful strategies on targeted approaches to reduce HIV incidence and prevalence. Regarding gender inequality, accurate and complete information on HIV infection and exposure could not be achieved in Zambia without closing the gender inequality gaps. And in Zambia, cultural marginalization and the stigmatization were heavy barriers to achieving health equity. And as a result, women were disproportionately represented in HIV interventions. And to gain optimal public health impact, the research suggested that the current HIV prevention programs in Zambia should have focused on women, individuals living in remote rural areas, and those with no educational background. In other words, HIV/AIDS prevention programs in Zambia should have implemented a tailored approach to address gender, cultural deprivation, education, poverty, and age-driven issues on HIV risks. Limited access to the hard-to-reach population was a challenge encountered during the research, and the research findings could not be generalized due to this limitation. And self-reported information introduced information bias into the study. And participants' ability to accurately report data could have led to inaccuracy in the data that was collected. And there was a possibility of underestimating HIV and AIDS incidence and death cases. So what is the practical application for the research? So like we said, although there was abundance of research on HIV and AIDS prevalence rates, there was limited research on HIV incident rates. So the results of the research added value to the literature on HIV by addressing the reason for the increase in HIV infection in Zambia, despite the MDG targets for Zambia mentioned to have been met in 2015. Also, the findings from this research could have provided new information and a deeper understanding of the HIV/AIDS problem, which could have been utilized by planners, policymakers, lawmakers, and the Zambian people at large. And then consequently, new policies and interventions developed from the insight of this research could have considerably reduced new HIV infections, which continued to negatively influence the performance of Zambia's fundamental social and economic development. So, what are the practical applications for social change? One, improving access to adequate food security reduced the risks of HIV among vulnerable poor communities in Zambia. Furthermore, promoting gender equality in all sectors of life in Zambia, empowered women to have the power to control their sexual practice decisions and the voice to stand out and protect themselves and others, for most importantly, prevented HIV transmissions in Zambia.
This is amazing. Thank you, Dr. Ketty Ngona. After practical application now, I think it's time for you to go back in Zambia and work with all the Department of Public Health, their medical practitioners, and all the teams. And one thing I like about Africa Now is that they are open-minded in welcoming people from diaspora to participate in a lot of work they're doing. I can't say anything more or less on what you have done. You have done amazing work. You know, the idea of looking into gender and looking into marital status, I don't know what's the implication in future research about the widows, why the widows have, I have my my guess, but a guess is not a good enough as evidence-based research to figure out what it is that made them more vulnerable for HIV positive. It will be interesting to further explore that. And then obviously, definitely pro-women agenda will continue in Africa to you know, make sure that women are receiving necessary things they need for their protection, for their health. And that means that it takes a village. It's not gonna be something easy that we just have to sit down and, you know, ignore it. Any person, especially whether it comes from chronic condition or infectious disease, if it's specifically infectious disease, it's a danger to everybody because anybody can get it through the route of transmission. If it's sexually transmitted or if it's airborne, it's even more dangerous because you don't have to even be in contact with that person, you will get that condition. So that's why all this type of things is very, very important. So I think it will be a good time to work with the policymakers back in Zambia to see how you can help or how can your study inform other best practices that they're already working on. That being said, it's now the opportunity for me to open this whole thing up for everybody to actually have the opportunity to either ask me a question or ask Dr. Ngona a question regarding her presentation. So I will, oh, by the way, before I open it up, Daniel Nwankwo made a very good comment, which I already responded in the chat. He said, let me read. Let me read what he said. Since women were more reluctant to take part in the study, with just about 4% of the population study, why was this? And that's a question to you, Dr. Ketty Ngona. And I think you already a little bit touched on it. And then after you answer that question, then we go to Dr. Nemeka Nwaka, which has his hand up. So this is a question from Daniel Nwankwo, asking about women.
Yes, like I mentioned earlier, the cultural background in Zambia really marginalized the women. They don't have a voice that much where they could come out in the open and even, you know, declare their status in as far as HIV is concerned. So most of the time they are just left, you know, enclosed in their own problems until they die. So that's the reason why most of the women didn't even have a chance to come out in the open to say, to declare their status. And to them, if they come out in the open, it's like a taboo. They are breaking the cultural, you know, barriers where they come out and speak out. So very little, you know, choice is left to them. It's just now that a little bit women are understanding a little bit, especially those in the city, they are able to understand their stand and be able to speak a little bit more. But when it comes to the remote areas where they practice a lot of cultural beliefs, it's very hard for them to actually come out and participate in any program that comes along. So that could have been the reason why the number of women could not participate in this research as compared to the men.
And to just add to that, my thing is, I'm wondering if a married couple, if the wife, example, is positive, obviously, let's say the husband is not positive, whether the taboo also exists that the husband will not want the wife to actually get a better health care or, whatever. You know what I mean? Beside what the outsiders will say or beside what external things that will be happening as a family unit, I can also understand if it's a single woman, it just probably ruined their life, right? Or if it's a single guy, man, it also probably ruined their life at the time, right? Now that we have cure, but it will be interesting. I don't know if you have the answer to this question. It will be interesting to see if there's internal support by married women being supported by their husband for this type of situation, right? It will be interesting to do that study to figure out how is the support system from the husband.
Yeah, I think that would be an interesting study to look into that, because in Zambia, a man is like the head of the house. So very little will a woman be there. But I think that's a good idea where we want to go further and understand how do they take the status when somebody's HIV positive, how is the support from the inside of their family, their nuclear family.
Thank you so much. Now, I'll go to Dr. Nemekawaka. You can unmute yourself or be on video if you want and pose your question. Sorry for waiting. Dr. Waka, we can't hear you. If you're speaking, we can't. Dr. Waka, are you there? Okay, we're not hearing you. Let me see.
Post the chat.
Okay, let me check the chat and see if there's anything he posted, but I cannot hear him. If any other person has any other question, you can pose your question while we're waiting Dr. Waka to connect somehow.
I have a question.
Okay, go ahead, Doc.
Hi, my name is Dr. Marlene Trusiak, MD. I am in California, United States. I hope everybody is doing well. When I am a member of LinkedIn, and when I saw your page that indicated there was a meeting, I wanted to go. And so today, my one day off, I woke up early so that I can participate. So thank you for having me.
Thank you.
Yeah. The reason why I was interested in hearing what's happening in the other part of the world is because I have an organization that does just that. We do a HIV/AIDS education, follow-up, referral, and a number of other things associated with that. It's called Doctors of the Globe. However, I listened to your research, Dr. Ngona.
Yes.
Yes. Okay. Very well done, by the way. Very well done, because I've written a few myself, and you did a great job. All right. So based on the implications that you stated earlier, and I know this question has been answered in some form, it seems like mine is a question and a comment at the same time. It seems like you said there was a 3% difference between men and women. We putting aside education, marital status, or whatever. of people, seems like there's a higher rate of HIV in the number of women who have reported and who have been found to be positive. Mine, having taken place in a lot of research and overseeing some, my suggestion was, my other question was, it is statistically significant. However, have you determined the clinical significance of all that? Does the statistical significance match the clinical significance? I thought, honestly, it was the other way around, but I can understand in a country where women have no voice and they don't have access to a lot of government program or whatever. So my question is, if you were to establish some kind of protocol for treatment for these people, my suggestion would be to start with women first, because they're the one with no voice.
Yes.
And it's my experience, even in the US, in the lower socioeconomic groups, if let's say the women were the one at home not working, were to be the one to have HIV and the male didn't, the couple disintegrates. In this instances, you would see that they stick together, pardon that expression. It's in the higher socioeconomic group where, you know, both partners are independent financially, they will stay together. But in the lower socioeconomic group, the couple disband in the majority of the time. And that is an observation based on the people that I see on a daily basis and I have to deal with. All right, so I would say my suggestion would be to start some kind of program, maybe a risk assessment questionnaire. You said that the people way in the boondocks where there's not a lot of traffic don't have access. So if you had a risk assessment questionnaire to be distributed in this area where people would respond, however, anonymously to whatever number or headquarter that you establish, therefore you would have a greater and better number of people come in, and then you could start from there. These women would receive, or you would establish, and it takes money, it takes a lot for that. So you would establish some form of education, not to teach them to read or write, which, although that's important, but you would establish some form of education so that they know, because the women are the one to say, yes, I want it. No, I don't want to do this. So you start with them first, because, you know, as they say in the vernacular, men have urges, but the woman is the one to control those and to be able to say no. So we would start with these women first. Risk assessment questionnaire, having these people come to you, and then start dealing with these people. So that's my humble suggestion, having dealt with, since I have a clinic in Haiti at this moment and a clinic here in California, dealing with just HIV, and it's as a humanitarian factor. That's outside of my regular work. So that's my suggestion. But your research, well done, really great. And if you could answer the question for me, this statistical significance versus the clinical significance, I'd like that. Thank you.
So when it comes to the clinical and the statistical question that you posed, thank you for the comments and thank you for that contribution concerning, you know, being on the ground to be able to carry out the research, you know, in person than using the archival data. I think that would be a better way to go. But when it comes to the statistical and significance, like I mentioned in the people that contributed to this research compared to the men and women, as you can see, the women, even though the number that participated showed to be less than the men. And when I looked at the ratios there, it was showing that every 8 women who stated their status, one of them predicted to be HIV positive, as compared to the men who were 10 out of the 10 men who were positive, I mean, who stated their status, one out of 10 was positive. So as you can see, if we look at the numbers, if the women also came in a number like the men came, definitely the women will be more positive as compared to the men. So I hope I've answered your question.
Yeah.
Yeah,
Thank you. Although not exactly the way I would have wanted to, but I'll accept that because I know I cannot monopolize the time.
yeah,
Everybody has questions, and hopefully, maybe in the future I'll reach out and ask questions to your group. I'm not sure if it's a group. I don't even know who it was, but I will look again to see whose platform it was, and then I'll probably reach out to that.
yeah, Dr. Marlin, that's my platform. So you reach out to
Thank you.
people. Let me add to that question. That's a great question. You know, I do this a lot, and people perform studies and say significant difference or not. I say, you know what? I prefer public health significance any day, clinical significance any day over
Mhm.
statistical significance. That's me
Absolutely.
personally, hands down,
Absolutely.
you know, because
Absolutely.
the clinical and public health significance is the reason, the basis where we do the work we do in public health, right? So
Correct, correct.
I look into that. And also what I do look also in a research is not just merely statistical significance. I also look at relative risk. I looked at, you know, if you do odds ratio, I look at that because
Absolutely.
those two things
Mhm.
is what informs clinical significance or informs the public health significance. That's where you go, right? So that's a great point. And I'm sure that Dr. Ngona had those stuff because since she did logistic regression, those numbers are there. But you know, you just, you know, you ask the real question most scientists don't ask, because that's usually what I do. I say, you know, okay, you present all this, okay, what is the public health significance?
Yeah,
Since public
absolutely.
health, in terms of you're into medical, you know, area, so you went straight to the point that will help you
Absolutely.
provide care to patients and know
Absolutely.
the specific
Absolutely.
target that you want to present care to.
Yeah,
Perfect question. Thank you
and
so much,
also,
and thank you
yeah.
for all the compliments about this podcast.
Also, and then my goal was not to call you out. It's to ask the specific question that I needed to in order to be able to understand the data that you presented, because
Right.
I am a PhD doctor in public health, and I also I'm an MD. I'm a medical doctor as well, and I do the cases that I do when I write research and I see the research and I treat the particular element of the research without the people. So I did that both hands. So, and I can get it from that. So thank you so much. Really, really appreciate it. That was a great platform as well. Mr. Organizer, I can't see your name, but
It's Ndukako Melo. Just reach out to me through LinkedIn. Maybe, you know, I'll be interested to actually invite you in public to present some of the work you're doing. That's amazing. Thank you so much.
absolutely,
I
if
really
time
appreciate
permits,
it.
I would be delighted. Thank you so
Okay.
much. Great.
And
Okay.
then I think Dr. Waka now, can you talk, or do you just want me to read your question? He put his question in the chat. Okay, Dr. Waka, we still cannot hear you. So there's something else going on with your network over there. Either you have yourself on mute somehow. So let me go ahead and read his question. My question is regarding the cross-sectional survey targeting adults 21 to 65 years old. Why was the time limited to 2018? Okay, what type of sampling was used, since I now understand that you conducted a survey using a tool? Then would a larger time interval like 5 years, say from 2013 to 2018, have changed your findings? Like the one about 2% of women were HIV positive. So this is Dr. Waka's question. Do you want me to repeat the question, or you got it?
So looking at the question, I think if you can repeat, I heard partially.
Okay, so let me summarize. The question is that why do you use 2018 data? Why not And then he asked, what if you have used 5-year data series from 2013 to 2018? Would it have changed anything in your result?
Probably yes, probably not. The reason why 2018 came up was because of limited data, like I said. What was used was archival data, and not too much information could be given by the Zambia Research Department. So definitely if it's a longer span of data, that would have contributed to some changes in the results that were given out. So with, of course, maybe using the in-person research where you do the questionnaires yourself and collect the data, I think that can be a better way to get better results than depending on the archival data, because what you get, what they have is what you get. So, and it was a little bit harder because it was during that time of the pandemic where very limited movement was done. So it was hard even to get a lot of data that was needed. But I agree with you. I think using a longer span can change the results.
Okay. Did anybody, any more questions?
Yes, Dr. Omalo.
Go ahead, William from Canada, go ahead.
Yes, Coach William Power, based in Toronto, Canada. And my work is over 35 years, endorsed by Harvard Medical School, Oxford, and well, 90% of my work is remote psychology of healing. And I want to say that the information that you presented and the results is absolutely correct. But I wanted to add, from my experience, to help you and others to understand from another perspective, and that is why it would be, say, more women in Africa and, say, less women in America, and so on throughout the world. Because I've worked in America, I've worked in the Middle East, I've worked in Africa and other places in the world. And the common denominator, whether it's a man or a woman, you're touching upon the answer. But I'll give you more of from my findings as how I go laser-like right to the reason for this. And that is the person, whether it's a man or a woman, the person, okay, is feeling defenseless, inadequate, hopeless. Nobody cares. And they also have sexual guilt. So if you throw all those feelings in the body, it produces this state, whether you're a man or a woman. And the way I've been able to reverse this kind of disease in this way and others is through having that belief or that feeling change, so that someone really has the ability to love oneself. It's as simple as that. So I want to leave you with that. I don't really have a question, unfortunately. I'm not trying to sell myself. I'm just trying to add to the answer for humanity around the world, because there needs to be more love, and that's one thing that is lacked. And it's self-love. It starts with self-love. And again, those people, whether it's a man or a woman, they're feeling defenseless, hopeless. Nobody cares. And they have a sexual guilt as well. So if you put those things together, that frequency, that feeling and frequency produces that kind of sickness. And this is why I'm endorsed by these establishments, is because it's above and beyond of what is taught in medical school. So I just wanted to offer that, and lots of love to you all.
Thank you so much, Williams. This is amazing perspective because, you know, and just to add to what you said, I mean, virus is real. There's no doubt about it. It's been identified in the lab. But to add to what you just said is that we know one thing. There are some other things we know. We know, for example, stress induces expression of cortisol. And we know that cortisol weakens your immune system. Now, here the connection right here, right? And I totally 100% agree with you that, you know, depending on how you feel about yourself, the mental health aspect of yourself, the maybe, you know, spiritual aspect of yourself, there are certain things your body is equipped to within to be able to fight certain things, even when you're taking medication. But when you're actually incapacitated by a lot of stress, it also weakens your immune system and how your body and how your system respond to medication or respond to any type of healing process. So, you know, and interestingly, CDC now and many agencies are now also focusing on the direction of mental health and stress, because we know that these are linked to not just weakening your immune system, it links to adverse health events, including chronic conditions. So that's a great point. You know, this is one of the things I might be talking about, because my schedule is full now for a lot of podcasts, but maybe next year is something that I will explore into, inviting people like you to talk about this type of approach, you know, which is holistic approach with medical aspect of it. So thank you so much for that question. I think there's a comment here from Dr. Emenambo. Oh, Dr. Emenambo, do you want to speak on it, or you want me to read it?
I want to speak briefly, just 1 second.
Okay.
I just want to lay some emphasis or speak on it because during the introduction of this program, you will find that South Africa has high incidence of HIV/AIDS globally. Right? You want me to?
Yes.
Okay, yeah. So I need to lay some emphasis on why we have high incidence of HIV in southern portion of Africa. We have to remember that around the latter part of 1980s, early 80s, that there were one in Angola, Mozambique, and also South Africa with its apartheid policy was more focused on the political incidents in South Africa. It said HIV epidemics emerged in South Africa 1982, I believe. However, I beg your pardon?
No,
the
go
country
ahead.
the country was at this point in the midst of dismantling apartheid. The HIV problem was, for the most part, largely ignored and silently, while political unrest dominated the media. And if you look at one of the factors that you always find there, they say high incidence of rape, and then lower socioeconomic group were highly infected by HIV. And these are the factors that have, even up to now, I think South Africa also have very high incidence of HIV because of this historic problem. That's all I want to contribute.
Thank you, Doc. Actually, I forget about all that historical context, but you're absolutely right. We're seeing that also in the United States in terms of access. Access, that's the term, access to care, right? When access to care is prevented, then many people that actually need those care cannot have the care they needed, and by then, you know, everything is spreading like wildfire. Thank you for that education and reminding us, that South Africa didn't just sit down. The people in South Africa did not just sit down. The Black people and other good people in South Africa did not just sit down and let HIV plague their community. Just the system, the overall system, prevented a lot of people from having access. Thank you for that. Any other comments or questions?
Hello? Can you hear me?
Yes, we can hear you, Rodney. Go ahead.
Oh, thank you, Dr. Emilio, and as well you, Dr. Ngona. I've really appreciated all of this information. And one of the things that I really appreciate here is not just the clinical studies, but how the social economical factors are also being, that some light is also being shined on those as well. The main point that I wanted to ask a question about is, Dr. Ngona, given the marginalization, and I'm talking about Zambia, right? For the
Yes.
Zambia, given the marginalization of African women there in the rural settings, my question is, would you consider doing some sort of test to determine the deterrence to social change there, given that that is one of the factors that may lead to the sisters there acquiring, or for lack of a better word, acquiring HIV and AIDS, or would considering the deterrence or those things that go against social change, because I can identify with that, within a certain cultural settings, in a rural setting in Zambia, that would be a factor. But the other part of the question is that even after these studies come out, how would government implement some laws or institutions or something to bring about change? Does that make sense, my question?
Yes, it does. And thank you for bringing up the question on marginalization. It's true that it's important that further study could be conducted to see what are the deterrents concerning the marginalization. Especially, I would look further into the rural areas, because I think the remote areas are the ones who are more affected, because they don't get the actual data or information that they need, the preventive measures that they need in a timely fashion, because of no access to communication techniques like TVs, radios, and the rest. Some of them don't even have the phones to communicate with. But if that was to be done, I think I would focus more on the remote areas who have no access to that information, to see how that can be improved upon, because what they need is the education to understand, how they can help themselves to prevent, further transmission of the disease in mention. And then also, like I said, when it comes to the government, so once the research is conducted, so I'm actually going to Zambia next month. So my mission is to see if I can meet up with the policymakers and be able to share the ideas and see how these suggestions that have come up from the research could be implemented in their policy making, as well as also in some of the decision making that they do concerning how to run their government.
Thank you so much for this. And I don't know if any other person has question. Otherwise, I'll go to close out this podcast.
Yes, I have a question, Dr. Melo.
Go ahead.
Yeah, to Dr. Ngona. I just want to find out what kind of education are we giving the providers as well as the individuals affected by HIV/AIDS in Zambia? I just want to know if there is some way of measuring, their knowledge base, if they understand what this disease entails and what steps, that they have taken from the education they have received to minimize exposure to HIV/AIDS.
There are a number of NGOs running programs. The only thing that I don't know much is to what extent and how far they are reaching, in especially the remote areas are concerned. And then also there are also programs that are aired on the communicative media, where a number of NGOs come on the TVs and be able to educate and disseminate the information. And I think in the cities, because I can talk from what I've seen in the city as compared to the rural setting. So in the cities, there's a lot of awareness as compared to the remote area. So a lot of changes, and people are coming out in the open to even utilize the resources that are being given to them. But like I said, I can't tell how much influence is on the remote areas, like to those people who don't even have the education, what mode of communication they are using to reach them.
Thank you so much, Dr. Ngona.
Thank you.
If nobody has any other question, I just want to remind everyone, thank you for coming. First of all, we really appreciate you coming and participating in this podcast and discussion. This podcast will be posted on YouTube probably tomorrow. Please subscribe to our YouTube channel, Popaholic Shows and Podcasts, please. Support us in YouTube and share the video when it posts to your friends and family. We know we're talking about HIV in Zambia, but that doesn't mean HIV is not occurring here in the US and other places around the world. Please, this is very, very important. Another thing I need to speak on before I close out is please remember August 12th, Dr. Tierra Riggs, amazing doctor, will be presenting on gestational diabetes research she did in Indiana among African-American women population in Indiana. You don't want to miss this particular presentation. There are so much stories in this. This is a qualitative study. This study is an amazing study. It's one of the best studies I've ever seen in qualitative studies. So please, I will be sharing the flyer sometime this weekend or next week. Put it on your calendar, August 12th, still on Saturday at 3 p.m. Eastern Standard Time. And in September, I think September 30th, Professor Faciotti and Dr. Faciotti will be presenting both from UC Davis University. They've been doing amazing study in a research setting about tissue engineering and articulate cartilage. That another podcast you don't want to miss. I know some of you might not be molecular oriented, but they're gonna keep it simple. This is a research, university level research. So I'll be also sharing that as soon as possible. when I receive all the information. But other than that, I have to close out again, coming back to the quote, the worst enemy knows everything about the prey, and the prey knows nothing or little about the enemy. HIV and AIDS are the enemy, and for over 40 years, HIV have plagued and continue to plague many communities, enhancing awareness and knowledge on how this common enemy continues to spread in the communities can help many people, and communities make informed decisions on best approaches to prevent and manage the spread of HIV. This sentiment applies to other emerging diseases and pathogens. Remember, Popaholic is about healthy discussion, healthy people, and healthy community. It is about you. That's why we do this work. Thank you so much. I'm closing, but all of a sudden I have a hands up. Okay, 1 minute, 1 minute. Udoka, you have something to say? If you can, 1 minute, and for the sake of time, we had to end the podcast.
Thank you, Zuri, for coming.
Hello, can you hear me?
Yes.
Yes.
Okay, you're coming
Okay, perfect. I was gonna ask a question on like the new. So I don't know usually how people are treated nutritionally when they are diagnosed with HIV or AIDS in Zambia, but I know that like from my perspective, I'm a dietetic intern here in America, and we usually just recommend that our patients eat like polyunsaturated fats or omega-3 like fish. And I was just wondering like if people in Zambia or people diagnosed with this disease in Zambia also kind of get that nutritional support along with the clinical support, just because we know how like important nutrition is when treating viruses or like diseases like this to keep like a healthy immune system. So I kind of just wanted to explore that kind of aspect in this type of research, if that's okay. Dr. Ngona.
I would say, you know, when somebody has even the effort to come to the hospital to be diagnosed in such a manner, definitely they will be followed by different medical professionals to help them, you know, not only to get, you know, treated for HIV, but also in the aspect of nutrition, because without nutrition, no matter how you take your medication, it's not going to work. So, but the question is if that person will be able to manage even to get all the recommendations that they get will be something that cannot be answered.
That's great. Thank you so much. Like I said, thank you, Doctor, for the question. And in fact, your question fit into William's comment about, you know, what's within is usually part of the disease process, right? So that's it fits in because we are what we eat, you know, that type of phrase. But please remember that Popaholic is about healthy discussion, healthy people, and healthy environment, and healthy communities. It's about you. Thank you for coming and tuning with us on August 12th and September 30th. It's amazing 2 topics. And then after that, I will announce the other 2 topics we have coming. And thank you so much. Thank you for coming to this podcast, and have a wonderful day.
Thank you, Zuri, for coming.
Thank you so much, everyone.
Thank you.
Take care.
Thank you. Good job, Dr. Ketty. Thank you. Bye. Ketty. Bye.
Wonderful. Bye.